The Mental Health Commission is the regulator for mental health services in Ireland. We're an independent statutory body. The Commission's mandate is to promote, encourage and foster the establishment and maintenance of high standards and good practices in the delivery of mental health services. Under the 2001 Act, the statutory scope of mental health regulation for us is limited to inpatient services, so we have quite a limited scope in terms of the full mental health services. But we also perform a critical function in vindicating the rights of people who are put into mental health units against their will or in an involuntary way. Over the course of COVID, we monitored 181 residential mental health services, comprising 67 regulated inpatient centres and the rest community hostels. I mean, the written submission of the Commission sets out the number of concerns identified as part of our role in monitoring the progression and impact of COVID. I have to say, we found staff on the ground and people in the units, the clinical staff, indeed the management, really pulled well together. We couldn't say it was a success because people died, but I would have to say that the mental health services and the professionalism of staff protected many people. So I really do, I really want to emphasise that. What we found was actually that the national governance was a little bit behind, a week or two, maybe three sometimes, behind the actual services, and I suppose that's fair enough in that the services knew what was happening in the here and now. We found issues around facilities with shared accommodation and limited ability to isolate, lack of public health guidance specifically for mental health settings. We found delays and inconsistency in testing, and I have to say this was in the early phase, and I think, you know, we have to be frank, I think people were very much caught on the hop. There was a sense of, let's get the resources. There was resources from what we could see taken out of mental health and diverted into other parts of the system based on the thinking at that time. And there was also delays and inconsistency in testing and inconsistency in the continuity of services, and we also the suspension of community-based services. So, I mean, they're the key issues for us. Essentially, we come back to the main point. We've been given evidence to ministers, to the HSE, to basically anyone who will listen about our mental health service for the last 10 to 15 years. It's clearly documented, it's transparent, it's in the public domain. COVID has now shown us that we really need to address this, and that we need to put money into our capital infrastructure to make sure buildings are fit for purpose for people. We need to put money into making sure that our services are well staffed. And, you know, we need to set about building a proper community mental health service in Ireland. So thank you.
Mr Ryan, can I ask that you introduce your delegation from the HSE and maybe make a short comment outlining the key points of the HSE submission which has been circulated, and I'd ask you to be relatively brief if possible to allow as much time as possible for questions and answers.
Thank you, Chair. Good morning. On my left, my colleague Professor Brendan Doody, Clinical Director Lindara, Child and Adolescent Mental Health Services. On my right is the National Clinical Advisor Group Lead, Dr Amir Niazi. We appreciate the opportunity this morning to come in front of the committee. And briefly, you will have received our statement. And our role as a provider is providing services across the 26 counties, community, day, acute and long-term care. The COVID has obviously had a significant input on all of our services, as it has on all health services. And the lessons that we have learned have included that we have a very resilient and committed staff, and we've adapted well given the circumstances. The lessons that we have learned have certainly been taken on board, and we see that the challenges which the Commission and the Regulator has outlined to us, which we would share, are things we need to plan for in the future. Chair, if that's okay, I'll leave it at that.
Mr Ryan. So I'd remind, I suppose, members that they are speaking for 5 or 10 minutes and open the floor to members. The first speaker is from Fine Gael, is Deputy Carol McNeill. Go ahead.
Yeah, thank you. Thank you very much, and thank you for your attendance today. A couple of questions, please. My understanding is that the National Forensic Mental Health Services had no patient positive case of COVID. Is that correct?
That's correct.
Okay. What lessons do you think we can learn from that, and why do you think that was? What steps were taken at the different stages to ensure that that was so? Because, of course, that is a congregated, closed setting, as are others that we've looked at. But what has been different about that?
I think the early stages, a very clear plan of at the front gate to ensure that anybody coming in, their temperature check. Our public health guidelines were followed rigorously, and we ensured that where there were positive cases amongst staff, that we ensured that the cohorting was done effectively. And we also managed to set up what we would call an infirmary within the hospital, whereby we were able, if we had a positive case, we had a plan in place in order to deal with that. So I think we probably learned from what was going on in the rest of the country, but the clarity from the word go about what we needed to do from people coming in, obviously having to restrict visits was very difficult for patients and for everybody concerned, but it was the right thing, we had to do it. Also to looking at how we managed our staff, and also to ensure that we looked at managing contractors, etc., who were coming in. So all of those things, I think, we learned. It was similar to what was happening in many of our other centres across the country. But some of this is, at times, you are, I won't say lucky, but we worked hard to be lucky.
Yeah. Well, my congratulations to you, and also crucially to the staff at Dundrum in the Central Mental Hospital in relation to that. Could I ask just about the timing of the move to Portrane, which is obviously a much more suitable, dedicated facility for mental health detention?
Yeah, as you're probably aware, we actually moved 9 patients from Dundrum to Portrane to set up additional capacity within the forensic service as part of our response to COVID. The plan at the moment is we're awaiting essentially the handover from the builder. At the moment, our understanding is that will be towards the end of September. There will be a period then of commissioning and training, which is built into the transition process. So we're on track. We would hope for the end of the year.
Thank you very much. Could I ask the Commission, just in terms of mental health services and training, how are you going to deal with, for example, the training records with therapeutic management of violence, for example, where it's difficult in terms of distancing? Will you, I don't believe that that's happening nationally, you might just make an observation about that. And is there any possibility of making allowances for people when you review their training records for the absence of having been able to complete this training, if that is so?
Well, I'll just quickly say one point, and then I'll ask Rosemary to speak on the thing. Violence, restraining people, secluding people isn't therapeutic in any way, irrespective of what people call it. It's not good for people.
Excuse me, I meant the therapeutic management of violence. Excuse me, I didn't. If I've misspoken, I apologise.
Okay. Oh, sorry. Rosemary, do you want to?
Yes, we have taken it into consideration, the training records in relation to any training that relies on point-to-point contact between individuals. That would include CPR, manual handling, and preventative management of aggression and violence. And in our inspection plan for going back out into inspections, which we did this week, we have built in, I suppose, an allowance for that and how we're going to address it. And I'll ask Dr. Finnerty to address that.
Thank you. Yes, we've commenced inspections actually today, and we will be looking very carefully at services where training is difficult for them to do in light of COVID. We've always found over the years that it's extremely difficult for the services to release staff to do training, even in mandatory training. Things have improved over the years, but we're still not at 100%. And obviously this year we certainly won't be at 100%. We will take into account, as Rosemary has said, about the fact that people can't do face-to-face contact and do training in a group setting. So that will be taken into account.
Okay, thank you very much. Just on that and on the additional pressure of time for people working in the services, can I just ask how a patient detained under the Mental Health Act, how COVID is going to impact their, not just their detention, but the review of their detention?
Well, people are entitled to tribunals under the Act, and we're quite rigorous around that. There's a couple of thousand people, a couple of thousand tribunals happen each year. So we kept those tribunals happening. In fact, the previous, I think it was the previous government, changed the Mental Health Act to enable us to have the tribunals to vindicate people's rights. There is a little issue that we're a little bit worried about, in that making sure that people don't take that for granted and absolutely ensure people know their rights, so that the teams, really there's a bigger onus on the clinical teams now to make sure that people who are detained know their rights, and not to forget about that while keeping people safe, not to forget about their human rights. But it seems that that's going relatively well. Just to let you know, it's an independent group of a barrister, a consultant psychiatrist and a layperson who we recruit separately and independently, who scrutinise it quite rigorously. Yeah.
And could I ask just finally just about patient visits, for family visits for patients? That obviously has been difficult. What has been the impact of that, and what's the thinking about allowing that to reopen now? If I could ask you both, please. Both groups, the Mental Health Commission and the HSE.
The impact of COVID-19 on service users has been very difficult. The social distancing, the staff wearing masks, staff not able to come into the approved centres, and the suspension of visits. And that has been a really isolating experience for some people within the mental health services. As the visiting restrictions are lifted, we will see people being able to communicate and meet with their relatives and their families, but it has had an impact. But so have all the other measures and restrictions that have come into place because of COVID.
Okay.
If I may say, from the provider point of view, like Dr. Finnerty has said, obviously it has had an impact on our service users. Some of the things that we've tried to do is use technology. So, for example, some of our organisations like Irish Advocacy Network will have used iPads which would have been placed in the approved centres, which they can use to contact patients. And that has actually worked very well, and we think it has a lot of potential. So we have, I know in some of the child and adolescent units where child visits or parental visits would be a key element of the therapeutic programme. We've looked at even having where we would use one of our own vans or transportation, and parents would come in the car. So we've looked at a wide variety of ways of trying to ensure that there's a connection between the service user and their family. Notwithstanding the need to make sure that there is a public health guidelines are followed at all times.
Could I just ask you a bit more detail, because that was one of the issues I was concerned about, was children detained under the mental health system. Are you saying that the parents came, that you drove the child to be able to meet the parent in a different setting? Could you just explain what you did exactly?
Or I might ask my colleague, Professor Doody, who's the clinical director with the Lindara Child and Adolescent Unit, who has first-hand knowledge of it.
Thank you.
Very clearly, any young person who's admitted into an approved centre, ongoing contact with their parents is hugely important. And from very early stages, when we had restrictions with regard to visiting, we were very keen to put in place, obviously, a mechanism by which young people could keep in regular contact with their parents, using technology, using Skype, so that young people were able to use that means of using technology to maintain that very important contact. Clearly, that doesn't replace, obviously, actual physical visiting, and at the same time, we had to be mindful with regard to the restrictions under which, obviously, that the units needed to take to limit the spread of COVID and all those public health considerations. But in the last number of weeks, the inpatient units have been able to reintroduce visiting by family members and parents on a limited basis. So that has been rolled out across the CANS inpatient units across the country.
But in the interim, did you say, it was solely by technology or by...
That was in the early phases. It was by technology, but in the last number of weeks, visiting has recommenced on a limited basis.
Just to contextualise that, just for the committee, what's the typical period that a child would be in detention in that way, please?
Well, the average length of stay in inpatient CAMHS units is about 40 days, so that's about the average length of stay. That will vary. For some young people it's shorter, and for some young people, depending on the reason for their admission, it can be much longer than that. But we're looking at, for example, I can speak in Lindara unit, that we've now moved to visiting twice weekly. And again, that is under obviously restrictions and taking into account the restrictions because of COVID and minimising the risk, because it's also important, again, as you open up visiting, that you have to manage the risk of introducing, COVID into the inpatient setting. So it's a balance. It's managing that risk and at the same time facilitating very important contact young people have with their family.
Thank you.
Thank you, Deputy Carl McNeill. The next speaker is from Fianna Fáil, Deputy McAuliffe.
Thanks, Chair. And thank you to the witnesses to the committee. I want to first of all focus on the access to mental health services, and as we know, even long before COVID, it can be problematic to access those services, particularly after hours. And so I wonder if you could provide us with a sort of a progress report as to how you expect the child and adult mental health services to resume, and the challenges that COVID will place in delivering those services, and will we expect to see further waiting times or a reduction in service delivery?
Well, just from the Commission's point of view, I'll pass you over to the Inspector, but I just want to emphasise that there was a report published this week by the HSE, for example, that shows there are significant issues around waiting for people. And to put it frankly, our mental health system is not fit for purpose and is out of date. And we need to invest in it, and we need to invest in the community. So what you're seeing if a child is lucky to get into a unit, they're very, very lucky. And actually you find in the services we regulate, the children's services and indeed the private services tend to be of the highest, of a relatively good calibre. But there is no doubt, until we invest properly in our community services and stop kind of making excuses that we kind of have some sort of a service, really what we're looking for our children is not going to improve to the degree it should be in this day and age. Susan, did you want to comment on that?
Yes, specifically during the COVID-19 crisis, access to some services has been limited. This would particularly be the therapeutic services and programmes offered by occupational therapists, psychologists, social workers, because they haven't been able to get into work. Now, there has been some move to, and Mr. Ryan alluded to this, to use video conferencing and video techniques to actually enable people to have therapy sessions. But there would be no group work, there would be no skills-based programmes in the hospital, or in the approved centre. The other thing is the access to community services would actually be quite limited at times, simply for the same reasons that people are unable to attend their occupational therapist, social worker, psychologist or other therapists because of the COVID. So access to non-medical, non-psychiatric treatment has been limited, and it's been very inconsistent around the country's widespread variation in where services are able to provide therapeutic programmes and where they're not.
And from the HSE?
From the HSE point of view, and I may ask if your question is specifically around CAMHS, I might ask Professor Doody, but initially the secondary care mental health services are being provided through our community mental health teams, our day programmes, our acute inpatient units, our long stay units and our community residences. they have been affected in a variety of ways. But for example, at the moment we're operating at approximately 91% of our pre-COVID capacity on our acute units. The areas in which we're challenged most is probably on our day programmes and the therapeutic programmes, because that requires much more significant face-to-face contact between patients and clinicians. And so from that perspective, we're having to look at creative ways in which we manage that, and our looking at things like, for example, Attend Anywhere, which is one of our platforms that we use for engagement between clinicians and patients, has proven very helpful and very useful. But perhaps, Brendan, from the point of view of CAMHS, might be useful to say something.
From an inpatient perspective, the demand for inpatient services hasn't really diminished appreciably during the COVID period, and the inpatient services, notwithstanding obviously the implications of COVID on service delivery, are running at about 85% of the number of admissions that would have been the case this time last year. And it's important to remember that last year's total number of admissions to the HC funded units was 308, was an increase of 50% in the previous year. So that has allowed, obviously the increased capacity has meant that obviously there are a greater number of admissions. Also there is it's allowed services to respond more quickly to admissions of children when inpatient treatment is required, and also a reduction of children being admitted to adult facilities. Clearly within the inpatient setting, obviously the restrictions with regard to service delivery, again, all young people have access to full multidisciplinary inputs. In the community services, clearly there has been a shift away from face-to-face consultation to more either using technology, using phone, but also other means of kind of video, such as Skype technology, where there can be video link, which again in some instances has proved very effective and very useful. However, it doesn't totally supplant the face-to-face interaction. So at this point, services are looking at how to, in other words, increase their capacity by which to deliver more services in a face-to-face context, and again taking into account considerations with COVID considerations, and then that involves looking at facilities, doing risk assessments. So there's a process in place, because with regard to community services, there was a fall off in demand for service and in the number of referrals received. However, services are expecting the numbers to increase and increase significantly as we move into, particularly when young people start returning to school in the autumn. This is usually a situation we find that there is a drop-off there's a reduction in referrals to mental health services during periods of school holidays. However, this isn't really a school holiday as we would have experienced known school holidays up to now. And again, young people remain under a significant period, a significant degree of stress. And I suppose one would expect there to be a pent-up demand for services. So it's important at this time services are planning for the expected increase in referrals that will happen after the summer.
So can you put a percentage on what the level of service is now compared to pre-COVID levels? Are we back at 80, 90% for the community setting?
Well, for the community settings, there was just, I can just have the figures here, that there was a kind of a 29.8, almost 30% decrease in referrals received. This is up to May. And then there was actually a 21% decrease in the numbers of new cases seen. So effectively what is happening is that the numbers of referrals are dropping. However, those with a more severe and acute need are still being referred. So even though the number of referrals dropped, the referrals still continued, and young people continued to be seen even during the COVID, during the early phase of COVID. However, it was those with a more severe presentation who are being referred and were being seen.
You alluded to, I suppose, the pent-up need that's there, particularly as we head back into the new school term and so on. I wonder, in the time available, if you could just outline how is the HSE at a community level going to respond to that need? Because certainly from my experiences, people who maybe haven't experienced mental health issues in the past have been profoundly impacted by the lockdown period and the change in society. And has any work been done in terms of planning for that expected need?
Well, I suppose when you're looking at planning, it's really, when it comes to mental health, it's everyone's responsibility. And I suppose we're just looking, I can speak from the Specialist Mental Health Services perspective. And again, work needs to be done in, as I said, education for parents, education for teachers, and helping and informing them such that they are more aware of the mental health issues that young people are going to experience because of what we have gone through. With regard to specialist mental health services, it's about how do we ramp up capacity to see the increased numbers of young people who will be referred. So that is you're now looking at within buildings, within facilities, how are we going to ramp up capacity, particularly you're looking for face-to-face consultations, and doing that in a way, obviously, that takes into account public health considerations and restrictions because of COVID, and that is very much looking at facilities. Also then looking at kind of programmes as well for how we might as well facilitate the use of technology, because I think that there has been quite a leap forward with regard to the usefulness of and the use of technology. And I think when we see, I think we will see in the future a kind of a balance between your face-to-face and also more kind of online and use of technologies in supporting young people who are referred to specialist mental health services.
Thank you, Professor Doody. Thank you, Deputy McAuliffe. Deputy Ward, I take it you're speaking for 10 minutes.
Chair. And I'd like to welcome the witnesses into committee today. I just want to thank Mr John Farrelly from the MHC there just for his very candid and upfront reprisal of what's going on with the mental health service by saying that it's not fit for purpose and it's out of date. I agree 100%. We can have no half measures when it comes to mental health provision, particularly with the onset of the Covid-19 pandemic. Like, it's only increased pressures on already under-resourced mental health services that were already there. I just want to ask the HSE, would they agree with that appraisal by John Farrelly there?
So we fully respect the view of the independent regulator, and clearly our role is to ensure that the resources and services that we provide are appropriate to the needs of the population that we serve. And so if you look at the last number of years, the increase in budget we've received, the increase in services, if you look at the last number of years, for example, when people speak about our premises, later this year we will open a new unit in Sligo. We've refurbished a unit in Limerick, in Tralee, new unit in Cork, a new unit in Drogheda. The National Forensic Service will be completed by the end of the year. So there's been quite significant investment in the infrastructure. That absolutely isn't to say that there isn't a need for more, and I fully agree that there is always a need for more resources in mental health, but working within the resources that we have and trying to make the maximum use of them, and also the staff that we have, which are highly trained and committed, which we've seen over the last number of months. So I think our role really is to make sure that with the resources that we have, that we make the very best use of them in the circumstances we find ourselves in. And actually we look forward to the vision for everyone, the new national policy, which is building on a very successful vision for change in 2006 to drive that investment into the future.
Okay, and just to follow up on what you just said there, like one of the biggest things that comes up for me when in relation to provide mental health services is to get staff and to retain the staff that's already there. Is that a challenge that's ongoing, or have you seen any light at the end of that tunnel?
So it is an ongoing challenge, and part of the reason for that is that our staff are very highly trained and very marketable across the whole world, and we have seen that over the last number of years. So, for example, on our psychiatric nursing, one of the things we've done is that we've increased the number of places in our third level colleges over the last 4 years, and this year we will see the first group of the additional nurses coming out in September. Well, they're already on units now because of COVID, and next year we will see a further tranche of additional nurses on top of those who would have been traditionally trained through the third level colleges. So that shows that we invested in that from the HSE point of view, because we saw the need for and the logic for those nurses. Similarly with consultants, where we've increased the number of BSD and HSD places in 2020 in order that we would have a better pipeline of staff coming through over the next number of years. Our AHPs, allied health professionals, it can be a challenge in some areas, particularly around psychology, but that's something that we are working on a continuous basis. So to answer your question directly, it's an ongoing issue, but one in which we're committed, because we want to try and ensure that we have the proper staff in place for our service users.
Great, thank you. So I'm going to move on to a separate kind of thing now. We've seen an upsurge in the amount of people drinking at home during COVID-19. We've also seen an upsurge in people presenting for treatment for drug and alcohol issues. And I want to really ask about dual diagnosis, because in going through the report today, I didn't see a mention of dual diagnosis there today. I've worked in numerous addiction centres right across Dublin over the years in a professional capacity. And we all know that drinking drugs give people the ability to self-medicate. It can calm an anxious inner world, and it works for a certain amount of time until it stops working. Like, it becomes a learned response. So the question I really want to ask is there going to be new services, or is there going to be additional services for addiction and mental health services, so they can work together instead of working apart? Because that's one of the biggest challenges that's out there. You can have a mental health service that are solely focusing on the mental health issue, or you can have an addiction service that are solely focusing on the addiction issue, and people are falling through the cracks of both of them services. So is there going to be an approach at some time where these services will be more aligned, and there'll be more resources given, especially to community addiction services?
Yeah, thank you, Deputy. I'll ask Dr. Niazi to respond to that. Just briefly, I worked as a drug task force coordinator back in the early 2000s, and I understand entirely the points you're making, particularly in relation to alcohol and substance misuse and the impact on mental health. So I fully understand the perspective. Maybe Dr. Niazi, you might respond.
Yeah, Mr. Ward, you're absolutely right. At the moment, the way we are delivering services is that if a patient has a primary diagnosis of mental health services look after him, and he might have a comorbid addiction issues. But if his primary issue is addiction, then our addiction services look after him, and we provide the support. But you are absolutely right. They are not working together. We are currently looking at a clinical program or a service improvement where the two of them can be working together. So I've already started working on it, and hopefully we'll be able to have a program announced very soon. It is in the program for government. It is mentioned very clearly in Sláinte Care program. So the integration of services is one of the key elements that we are trying to work on.
Thank you. And just go back to the drugs task force, and you mentioned that you're on back in 2000. I was also a member of a board of the local drugs task force myself, and the budgets probably haven't gone up since 2000, and that's the problem that the drugs task force are facing. And there's a lot of stuff. If, for example, to provide some sort of mental health service, our dual diagnosis service is not in the service level agreement from the HSE. It restricts drugs task forces then for implementing them. So they're like they're trying to fight something with one hand tied behind their back. And when something new comes in, because of budget restraints, something has to go out. So I just want to make that point. There's just another report that came to my attention yesterday. It was from the Child Care Law Reporting Project, which mainly relates to children being taken into care. There was a heartbreaking case yesterday in relation of a parent of a girl who had been admitted to psychiatric unit because of a serious eating disorder. There was no face-to-face permitted for the parents during the inpatient unit due to the COVID-19 restrictions. There was only access to Skype. The father in the court, and he agreed that his daughter was getting the right care and she was in the right place and she needed to be there. But he also emphasised how stressful it was on the family relationship and him as a father and in supporting his daughter while she's in there without having that face-to-face contact. So can I ask what protocols are being put in place to resume this face-to-face contact so families like this can at least see each other during these really, really difficult and challenging times?
Just to say that, yes, in the initial phases, and again in step with recommendations with regard to COVID, visiting was suspended, and that contact was, as the Deputy says, through Skype. The inpatient units have all reinstituted, these are the CAMS units, have reinstituted visiting. And the visiting is obviously mindful of COVID and necessary precautions are in place, but visiting happens twice per week, and again it's being reviewed on an ongoing basis. So once as soon as we possibly could reinstate visiting by parents, that was done so.
Thank you. And just in today's report that was issued today, many patients and advocacy groups argued that the mental health services need to be expanded and that the new government mental health strategy shared in the vision should be adequately resourced and implemented. We were talking about in the earlier committee as well in relation to the 12% minimum recommendation by the World Health Organization for in comparison to the overall health budget, and Ireland currently stands at 7%. Would that increase adequately resource mental health services across the state from 7 to 12%, or would more be needed?
Yeah, so clearly, as head of operations, I would always welcome additional resources being made available to mental health services, and over the last number of years we have seen significant additional resources, but there is more required. One of the things that we do want to look at is around our tiered level of care, and some of the contributions I understand that you'll have had earlier from Jigsaw or from Mental Health Ireland or Mental Health Reform will have spoken to that. We have a very strong relationship with our NGO partners, and part of that is about ensuring that where the HSE can fund external organisations to deliver, particularly on the more primary care, more universal supports, particularly where young people are concerned, but for the whole entire population, and in a way in which is much more flexible now. We've been trying to do that in order to try and reduce potential waiting times and also to use technology. So there are a number of organisations that we've now have service agreements with to deliver services on our behalf, and COVID has, I suppose, made that even more urgent than it was previously, but it's also made it more possible. So we would welcome additional funding, and if you look back at the beginning of Vision for Change, additional funding became available. There was obviously during the recession that wasn't possible, but that since 2012 there has been significant additional resources made available, and we would hope that under the implementation of Vision for Everyone, which is really the key element, that additional resources would be made available.
Thank you very much, thank you, Mr. Ryan, and thank you, Deputy Ward. Deputy Costello.
Thanks very much. I'd like to start just by picking up on some of the points Deputy Ward made there, the excellent point in relation to the failure of mental health services to meet the challenge of dual diagnosis, which is really significant. And Dr. Nisey, you say there that if it is a primary diagnosis of mental health or psychiatric services would deal with it. If it's a primary diagnosis of addiction is the primary issue, the addiction services will deal with it. My personal experience in working with supporting people trying to access these services is that both services claim it is the primary issue is the other service, which is what leads to people falling between the cracks, and is exactly the problem of these services not working together. And I think really fundamentally illustrates the point of Mr. Farrelly that the mental health services aren't fit for purpose, and I thank Deputy Ward for raising this really important issue. I'd like to just pick up on something also Dr. Finnerty said. You spoke around the inconsistency around the country in relation to sort of the community services. I wonder if you could talk a bit more about that, particularly focusing on areas that have done it well or you know, have what can we learn from them? What can the other services that didn't do it well learn from the services that were doing it well? Or, you know, what contributed to those services' success amid the inconsistency?
Right. I think regional variation is a feature of the Irish mental health services. There is no uniform staffing, no uniform provision of service across the country. And I think COVID probably has highlighted this in some sense, where the provision of therapeutic services and programs by allied health professionals, by a small number of allied health professionals, then when they were unable to deal with anybody during the COVID crisis, that really set it up in sharp relief that there weren't enough services, that there wasn't enough resources in the community services. The difficulty with, if there aren't enough resources in the community services, then people will naturally gravitate towards the admission units. And then that leads to a difficulty on discharge then, because there's very little follow-up. So the problem of lack of access to community services is not just part of COVID, but COVID has actually made it worse. Some areas are particularly poorly staffed with allied health professionals and consultant psychiatrists, and this can be for a number of difficulties, for example, retention of staff, difficulty in recruiting staff, people not wanting to work in isolated areas. So it's multifactorial. Also, that where there have been a history or a tradition of intensive provision of service, the funding will stay there. It is more difficult for areas where there hasn't been a very high provision of inpatient services, for example, when the old asylums were open. It's difficult for them to actually get the funding to match other areas. So there's a wide variation in funding, and there's a wide variation in staffing resources across the country.
Thank you for that answer. Also, just a few questions in relation to the mental health tribunals. You were talking there earlier, Mr. Farrelly, in relation to how the mental health tribunals were able to continue. Were there any challenges? Did you have sufficient commission members or tribunal members to be able to deliver them? Was there any legislative challenges, you know, in terms of, say, meeting remotely or anything like that? Is there anything that we should be looking at in case we need to sort of, we face challenges of delivering the mental health tribunals again in the future, that, you know, either positive lessons learned or things we would need to prevent? Well, mistakes made now that we would need to prevent. Thank you.
Yeah, I think it's been a very positive experience, because we're very clear that people shouldn't be deprived of their liberty unless they absolutely have to be, and their rights are vindicated. So working with the department, with the people who sit in the tribunals, our staff led by my head of legal, I mean, I think that was a good piece of work. The lessons learned, actually, the biggest worry was people going into centres, because people, a lot of people on our panels tend to be older, and there was worries around them themselves going in terms of secondary conditions, but it actually worked very well. We have to analyse it even more. The little bit of a worry in our head is just making sure that patients' rights are absolutely vindicated, you know, in terms of the solicitor representing them. Maybe looking at that, but we're all the time learning. But I have to say, in this instance, the HSE I think they performed well in this area.
Thanks very much.
The next speaker is Deputy Shartle.
Thanks, Chairperson, and I'd like to welcome all the witnesses. I want to start off by just asking some questions about children who have been very severely impacted by the restrictions of COVID, the fear, the kind of been closed in, loss of contact with friends and loss of involvement in school in particular, and the pretty severe impacts of those on children in the early stages of development. And we heard earlier from Jigsaw on the services they're providing for second-level young people. I'm asking now what services are in place or what programmes are proposed for primary school children, because we know that there will be significant issues arising. So are there specific programmes proposed? And presumably, given the long waiting lists for all children's mental health services, it would make sense to deliver school-based programmes. And also public health messages. So what is proposed for that age cohort? I'd also like to ask in relation to preschool children, and I think we're all very familiar with the terribly inadequate services for preschool children with potential mental health difficulties. The early intervention teams, for example, and we've probably all had experience of constituents whose children were on waiting lists that were so long that they actually aged out. They arrived at 5 before the HSE could provide a service to them. They may have been waiting for services for 3 or 4 years and aged out. So in relation to that cohort and primary school age children, what specifically are you intending to do to address the issues impacting them?
I can just answer really with regard to specialist mental health services. And although there is obviously children who are waiting for appointments, there can be some regional variation, and it's important to remember that over 80% of children referred were offered an appointment to specialist CAM services, were offered an appointment within 12 weeks. And
what period are you talking about?
Community child and adolescent mental health services.
Yeah, but what period are you talking about?
This is the
prior to COVID?
Up-to-date figures, yeah, up-to-date figures.
So I'm asking you, just in the context of the very significant impact of COVID on that age group, what specifically are you proposing now to address those needs?
Well, what has happened is in the acute phase of COVID, there was actually a decrease in referrals to specialist mental health services and community specialist mental health services, less of a drop in demand for inpatients.
Sorry, with all due respect, Doctor, I'm not asking you that question. And a lot of people didn't want to access services because of the dangers involved. I'm asking you now, given that we know there are significant needs in that age group, what services, if any, are you proposing to respond to that need?
Well, I think I can just speak for the specialist mental health services. What is important is that, and it's been spoken about earlier, is the restrictions with regard to the delivery of services, is how do we maximise the availability of community services to respond to this demand. And just because the referrals necessarily have not been made to date.
Yeah, sure. I appreciate that. Are you proposing any new services to deal with mental health issues in the primary school and preschool age cohorts?
Deputy, to answer your question directly, not at the moment. Remember that we're a secondary care mental health service. So one of the things that we work with is our primary care colleagues and our health and wellbeing colleagues, and also our contact with the school system. So I think it's probably something we will need to take on board. But at the moment, our focus has been on stepping back up both our primary care and our secondary care services for the overall younger age group. But I'll take on board the point that you've made.
I think it's disappointing that you haven't arranged any additional services. I mean, pre-COVID, your services weren't coping at that stage, and there's a clear need for additional services now arising from COVID. And it's disappointing that, we're now at a point where we hope children will be back at school in September, and no work has been done on developing new school-based services to meet that need. And I'd respectfully suggest that you need to get on with that job. I also wanted just to add to the points that have been made in relation to dual diagnosis. I mean, it never made any sense to be separating addiction and mental health problems. And, you know, that's a structural issue for the HSE, which should be resolved. But at this point, again, given the level of mental health need emerging as a result of COVID and what we know about the additional substance abuse and misuse in relation to alcohol, prescription drugs and illicit drugs, you know, surely now more than ever there's a very, very strong case for combining those two services and stop making that false distinction.
So I just want to respond briefly to what you mentioned earlier. We work obviously with the Department of Education, which is I think the most important thing we can do in relation to children's mental health. Because it has to be done in a very appropriate manner, and the schools are a key element of that. And I think your point in relation to dual diagnosis, I think Dr. Niazi has responded to that earlier, but we certainly take on board that there's a need to do more.
So are we going to see those two services being combined? And will you stop that artificial distinction between mental health and addiction?
Yeah, that's the target we are looking at. I've already spoken to addiction services and the leads in addiction services and mental health services, and a lot of work was done beforehand, but I need to bring it together and implement it. So yes, I can reassure you that we will be working on it.
And when can we expect those services to be combined and delivered as a single service?
I'm very hopeful that the process that we are working on, we will be able to submit a document very soon, and it's part of the program for government as well that we will be working on it.
Thank you.
Thank you, Deputy Shartel. The next speaker is Deputy Kenny.
I have two specific questions. The first question is in relation to the submission by the Mental Health Commission. So if you look at the first page, section 2, it says Mental Health Services Regulation. I wonder, could a spokesperson for the Commission define the use of unregulated? So I'll just read the paragraph. A further 10% are delivered within specialist mental health services, including a 24-hour nursing staff community residency, which are unregulated. So could they define what unregulated is, please?
So under the Mental Health Act, we register and we can monitor and we can take action in terms of approved centres. So they're the inpatient centres that are registered, and we have powers around that. In relation to all other mental health services, the inspector has the power to visit, but we don't have powers to make them, be of how they should be. So some of the hostels, for example, that people are in, or the community houses, they're really not fit for purpose, and that came across in COVID. So, for example, you could be sharing a room with 3 other people that you don't know, not family members, and I don't think anyone else in society, unless you have a really big family, kind of does that. So there's that element. And the other thing is the community, the primary care services. So if your child is unwell or you're unwell, you go to your GP or you go to A&E, and then you kind of get into the, if you need to, the idea is that you can go to kind of secondary services before you go to the final 1% of services. And the idea, as Mr. Ryan was saying, is tiered, that you see people as early as possible in their communities. So, for example, if you think of Clondalkin, you're not going to Tala Hospital. The services are in Rolla, or in Neilstown, or in Palmerstown, and you're met there or in your home. We don't regulate any of that. And in a way, it's kind of unfair on the acute units, because what you see with the acute units is, because we have a strong light shining on them, and a very strong light shining on them, there's a huge transparency. You see all the issues. But in fact, that's caused by not having potentially any scrutiny of the services out in the community, and they're not regulated.
Can I ask, why are they not regulated, and who runs these services?
Well, in law, it's the Mental Health Act hopefully is going to be changed to allow us to move out a bit more. I'm very interested in the vulnerable people, And I know I don't mean to be paternalistic, but the people who are become unwell, who mightn't have the supports in society, who fall through the cracks, as far as I'm concerned as a public servant, my job is to make sure that those people are protected. And they number in the thousands, it's kind of 1%. The reason they're not regulated is that the government policy is that they're not regulated.
Okay. Just the last question in relation to a spokesperson for the HSE, and I spoke earlier on the last session about the kind of, I suppose, the highs and lows of the public health emergency, and the highs were the kind of coming together of people, the solidarity and support that people showed with each other, and that was the bonding that people showed over them 4 months, and you can't buy that in some ways, but there was also huge lows to many people that have to self-isolate and not being in that gathering of, because we're social animals at the end of the day, and the loss of that has been incalculable. What has been the lasting effect on all, in some ways, the national psyche, but also to the individual of the last 4.5 months in relation to the issues of depression, anxiety and so forth, but what is the lasting effect on individuals and the population?
So, part of the challenge is at the moment we're not sure. Obviously, from research we've seen what has happened in previous traumatic situations, but COVID, considering it's with us will be with us for a considerable period of time, poses a greater challenge. I'm a member of the IMHL, the International Institute of Mental Health Leadership, and our international colleagues have done a lot of work on what are the medium-term effects. And the concern initially is that, as you say, there's a sort of a buzz about people coming together, and then there's a flatter period. One of the things that we need to try and ensure, though, is that from a primary care and universal support, as I was mentioning earlier, on our tiered level of supports, is that we don't say that everybody who is feeling down has a mental illness, because that isn't the case. We need to ensure that our secondary care and tertiary care services for those who need it most. But from the point of view of the more primary care, one of the things we've attempted to do is to use technology, whether it is Silver Cloud or My Mind, Spun Now, Turn to Me, any number of other organisations that we have funded in order to deliver additional counselling services and counselling sessions which can be delivered online. Because we do think that it's about giving people the tools in order to be able to deal with what we hope will be a finite issue, but one in which we now recognise is going to be with us for a period of time. So we want to try and make sure of two things. One is that we provide upfront services, but that also we make sure that the services that are required for those who have a longer term mental illness are not adversely affected either.
Is from the from the Rural Independence, Deputy Collins.
Thank you, Chairman, and thank you to our guest here today. The former CEO of Mental Health Reform, Dr. McDade, has advised successive ministers of state for mental health, senior civil servants, and HSE senior executives on solutions to improve the mental health service. She advises for the need to organise a cross-governmental, cross-society task force to develop the country's mental health recovery plan, with a commitment to publish the plan within 6 months. The groundwork for such a plan has been laid in the review of the National Mental Health Policy, A Vision for Change. This refresh was completed at the end of 2019 and is awaiting publication. It should be published immediately to provide a framework for planning the services that will prevent people from developing severe mental health difficulties and help people recover from their mental health and well-being post-pandemic. Dr. McDade is asking that the Government commit to the increase in the protected funding to implement the mental health recovery plan. She also recommends that we rapidly scale up and implement digital technology in mental health care at primary care and secondary care levels before the pandemic had even occurred. The HSE had been working for several years on piloting online mental health services. A major effort must be put in place now to scale up these initiatives in order to increase the reach and the capacity of services so that anyone who needs an intervention by a mental health professional can get it quickly. Dr McDade says that we must embed it in trauma-informed approaches across public services. Common sense tells us. She says that many people of all ages, from young children to those in their later years, will have experienced personal trauma during the pandemic. In a sense, we will have. But for those children whose families have struggled to cope with the isolation, who face sudden economic hardship, the threat of losing their homes, domestic abuse, bereavement or separation from a loved one who is dying, the personal trauma must be quite profound. Every teacher and school staff member, guard, health professional, social welfare officer, housing officer and provider of social care needs to know how to respond appropriately to their service users so as not to re-traumatise them. What is the plan to implement Dr McDade's recommendations in order to streamline the mental health service for the new challenges it faces?
So, Deputy, as if I understand you correctly, you're speaking about the Vision for Change Refresh, Vision for Everybody,
yes.
Which, as you're aware, was launched by the previous Minister, Minister Harris, a number of weeks ago. That's the government policy. I understand it's mentioned in, or it is mentioned in the programme for government, and that's we're, as a HSE, as a provider, we're obviously going to work very closely with the Department of Health from where the document originates as a policy document in order for it to be implemented. As you'll be aware, it's a 10-year document. And similar to Vision for Change, which was launched in 2006, the next stage has to be the implementation plan. And Dr McDade was involved, as you know, in the writing of the Vision Refresh document. So from a HSE point of view, we welcome the policy document because Vision for Change 1 was very helpful from the perspective of putting I suppose a roadmap for the development of services, also enabling us to secure additional funding. So we would expect that over the next coming period that an implementation plan with the support of the government and the Department of Health will be put in place, and obviously we would intend and hope to be involved in that.
Okay, thank you. Have the site visions or inspections to mental health facilities continued during COVID-19?
Yes, if I can answer that, Deputy. The inspections before COVID ended around the beginning of March. On advice, we weren't able to continue our inspections during that time. We have consulted with Dr. Kevin Kelleher in Public Health, and who now deems it fine for us to start inspections again, and inspections started last week.
Thank you. And how many cases of COVID-19 were detected in mental health facilities? Can you answer me?
I'll answer that question, and just to follow up from your previous question, we monitored all mental health services by phone throughout the period that we weren't allowed into the service. And we had over, I suppose, 2,500 calls over that period of time. We were in contact with services on a weekly basis, if not more often. So it was actually a very good relationship developing programme that we engaged in, and we have developed very good relationships with services on that basis. We monitored all the services in relation to suspected and confirmed cases. And as of, I suppose I'm pleased to note that as of this week, it was the first week that we have actually no cases to report within mental health services. Overall, the numbers that we had cases was, we had 28 services that had cases. That was 19 inpatient facilities approved centres and 8 community residents that had positive cases. And 47 services had positive results for staff members, 32 of them within the inpatient services and 15 within the approved, within the community residents. This is what services have told us. I suppose we are currently validating that data with services to ensure its accuracy. And that is the status as of this week of the numbers that we have.
Thank you, Deputy Collins. The next speaker is Deputy Burke, is it? and you're taking 5, is it? And then 5 and 5, yeah. Okay.
Can I just thank each of the people who are here this morning for their work, and you know, it has been a very challenging time for everyone involved in the healthcare sector, and certainly anyone involved in the mental health care sector, it's even more challenging. And just thank you for your contribution over the last 4 months in dealing with this very difficult situation, and all of the staff in the mental health area as well. Can I just ask, in relation to the total number of beds that are available within the mental health care sector at the moment, what is the total number of beds that are available, and what percentage of those are single occupancy rooms, and you know, what is the plan in relation to dealing with where we have anything up to 6 or 8 patients in rooms? What's the plan in relation to moving away from that type of facility?
So, okay, if breaking down the beds, we have approved centre beds, we have long-term beds, and we have high, medium and low support hostel beds. So I don't have the figures, Deputy, in relation to the single occupancy. We have approximately about 1,030 public approved centre beds, and there's, I think it's over 2,000 that there are when you take into account high support and continuing care beds. That's not mentioning medium and low support. So I don't have the details as regards the number of single occupancy. What we have done over the last number of years, if you look at our new units, particularly on the approved centre size, is that the majority of them are single or double occupancy rooms. So we have tried to eliminate multi-occupancy, and certainly in future our latest unit that's going to design stage, which will be in Lakeview, will be single occupancy.
And just on the multi-occupancy issue, and where COVID did occur in facilities, did that tend to occur more where you had multi-occupancy rooms as opposed to where you had single occupancy rooms?
It may be useful for Rosemary to respond.
Yeah, I can address that. From our monitoring of the centres, we have a fairly good oversight of it. Initially, when we started our risk assessment, there was only 25% of services that could provide single accommodation. Now, in fairness, the HSE moved rapidly on this, and within a very short period of time, the majority of services were able to provide single room accommodation. In relation to the current status, all of the inpatient approved centres had the ability, with the exception of 3, to isolate up to 2 people. Due to reconfiguration, there was only 1 service that is not able to do that. So every approved centre out there at the moment has that capacity.
Would you agree that 2 is not adequate in any one of these facilities?
Yes, that was going to be my next point, in that a lot of them are dormitory styles, 4 and 5, 6 bedrooms, and they were reconfigured in a lot of situations to accommodate social distancing. However, that has an impact then on other types of facilities like therapeutic services, because those areas were used to cohort patients.
And have we a target set in relation to goals to be achieved in this area? Is there a time frame in which we're going to try and have the single occupancy issue dealt with?
I suppose that's one of our concerns. The Commission's that in relation to disease management, it has worked very well, but in relation to disease progression, it's something that needs to be addressed, and perhaps the HSE would like to respond.
So, Deputy, we have a multi-annual year investment programme in mental health services, and obviously COVID has highlighted the need to further to expedite that, because our multi-occupancy rooms are the ones in which our greatest concerns are in relation to the spread of disease. So that's something that we, as we speak, we are advancing.
Okay, can I just ask one further question? That's in relation to facilities for staff. I received a number of calls where staff expressed concern that there weren't appropriate changing facilities available for them when they came to work and when they were leaving work, and this applied exclusively. All of the complaints I got in were in relation to mental health facilities.
I'll be honest with you, Deputy, without the details, I might not be able to answer that directly.
Okay, can I just ask so that maybe you might come back to me in writing, confirming that there is appropriate changing facilities for staff, both in arriving at work and in leaving work, in the same as what is available in our general hospitals? Because my understanding in the calls I've received was that there were no facilities for staff changing in some of the mental health units.
Thank you, Deputy. I'll do that.
And could I get that in writing, confirming that each unit now has the appropriate, whether it's changing facilities, whether it's showers, that they're available for staff who are coming on duty and who are leaving duty?
I'll respond to you, Deputy, in writing.
Okay. And finally, can I just ask in relation to the number of patients who contracted COVID within the mental health setting, what kind of numbers are we talking about that were directly affected or that contracted COVID? And what kind of numbers of staff are we talking about?
Okay, I suppose those are the figures that I gave you earlier, Deputy. The numbers were quite low within mental health services, which is good. So just to reiterate, there were 28 of service users and 47 staff members contracted.
For the entire country?
Yes, that includes both independent public services and private services.
And the number of bereavements?
We had 17 bereavements.
Out of the total number that were in mental health facilities across the country? Yes,
and that includes the acute units, inpatient units and community residential units.
Thank you.
Thank you, Deputy Burke. Deputy McCall, if you're...
If I could just come back to questions which I had asked.
Try 5. Is
Sorry.
5 or 10 minutes?
5.
Right.
I just wanted to come back to the question from Professor Doody from my first round of questions, and it's been touched on since by other deputies, and that was the inevitable impact on mental health, perhaps by those people who haven't accessed mental health services before, and then the altering of treatment plans for people who are already engaged with the service. And going back to the point that John Farley made at the beginning, and I would agree with him, and many other deputies have, the idea that our current community mental health services are not fit for purpose. And although we've talked about returning to some level of service that resembles normality, it seems very clear, and particularly in the answer to the question around there not being any new service for primary school service, for example, has the HSE examined what the expected increase in demand for mental health acute mental health services has been? That answer hasn't been fleshed out here in the chamber, and what it inevitably means is that we're going to have a further reduction in service for those people who are in real need.
So, I suppose to answer the Deputy's question, obviously the ability of services to deliver the type of service that was delivered pre-COVID obviously is not feasible. However, services have to look at how are we going to deliver the service, maximum amount of service, the maximum number of young people who require the service at a specialist mental health service level. That's both. Now, with regard to children and adolescents accessing specialist mental health services, the majority access community mental health services. And we're looking at numbers of referrals per year, just again approximately about 12,000 referrals per year being seen by community services. So the first challenge is that how do we maintain that level of activity, being mindful of the restrictions with regard to being able to deliver the service, with regard to the public health considerations and the need to minimise the risk of spread of COVID. So what we have to do is to look at probably the service, a new service as usual, which is both delivering a service obviously face-to-face, but also looking at remote access, use of technologies, and a more blended approach. But at the same time, we do need to scale up services in anticipation of an increased demand, because we know from, as I said, as Mr. Ryan said earlier, from international research and even surveys of currently of young people with mental health difficulties, that the COVID pandemic has had a negative impact on their mental health. And that we need to be mindful of this and mindful that as we live in this a time of increased uncertainty, we would expect increased levels of anxiety disorders and other mental health disorders, and that we need to look across the spectrum, be it from how are young people supported in their mental health, right across services from community to primary care to specialist mental health services.
And Professor, when you say scale up, are you saying to this committee that we can have confidence that that is being done and will be done?
Well, what we're doing, and I can speak for our own services, is looking at how can we, again, looking with regard to the, the restrictions with regard to physical, to contact, face-to-face contact, how do we maximise the access of young people and families to services, with the considerations that services will have to work under for the foreseeable future.
Okay, can I just touch also on the point of the dual diagnosis issue, which was also raised, and I'd like to address it to Dr. Nazi, and I very much appreciate the assurance which you said that you'll be bringing forward reports. I know the programme for government does talk about both the protocols and the legislation, and I'm no doubt he is already familiar with it, but I had the great pleasure to attend the launch of the Fingers Addiction Support Team, who carried out a dual diagnosis research with Dublin City University, a very thorough body of research, and they outlined 4 key recommendations, including changes to the Mental Health Act, which talks about there being no door being not an option, the idea of a clinical lead and a clinical programme, around dual diagnosis, and also the training, the changes in training and education for those people who are engaged in both, so that they're seen as both sides of the same coin. And perhaps there'll be an opportunity, Dr. Nazi, to discuss that with you in further detail when the committees of the House are established.
Thanks. Thank you very much.
Mr. Niazi, did you want to come in on that point, or do you want to wait until maybe discuss it as Deputy McCall has suggested, maybe at the Health Committee when when you'll be able to go into further detail?
As I say that we have already started working on it. I think I'll be in a better position to answer that once I have done the homework and have rolled on the program. So I think I'll be in a much better position. But I've already started meeting with the key stakeholders for it. So I think all I can say is that even before this meeting, the work was already started.
Thank you, Dr. Nazi. I'll forward you on a copy of the report, which I'm sure will be useful in your work.
Thank you. Thanks, Deputy McAuliffe. Deputy Cullen.
Thank you, Cohorts, and can I welcome all of our witnesses. My first question is to Mr. Farrelly. And first of all, can I commend you and the Commission for your work. I've read your 2019 report. I also read your 2018 report in advance of this meeting, and I have to say they both make for very sobering reading. Mr. Farrelly, you said on the 2nd of July, in a press release, I think it was, that accompanied the publication of the report, that too many residents in acute psychiatric settings or mental health settings in acute services are still being treated like second-class citizens. Is that correct?
Correct.
You also said that the fundamental human rights of patients were being overlooked. Is that correct?
True.
And you said that many mental health residents are still being admitted to outdated and unclean premises. You also went on to say that the Commission has consistently and repeatedly underlined the failing in our mental health system, and yet these shortcomings are yet to be acted upon. Is that correct? Can I come to you, Mr. Ryan? Is it your responsibility to make sure that those shortcomings are indeed acted upon?
So my responsibility as a head of operations is working with my 9 chief officer colleagues and head of service colleagues throughout the country in the implementation of our mental health services. So the comments that have been made by the regulator, and I absolutely appreciate the role of the regulator. And as I have said earlier, what I have to do is to work with the funding resources and staffing that we have in order to try and make the best use of those resources.
I asked you, was it your role? So I'll get to what you do in a few minutes, because that's fairly obvious what you do. But I asked you, have you a role in making sure that when the independent regulator points out shortcomings, that those shortcomings are addressed? Are you the operations officer that in the HSE that deals with acute psychiatric settings?
So I'm the Assistant National Director for Mental Health Services.
Okay, so yes is the answer.
That's correct.
Okay, and the report goes on to cite critical risks in a number of areas: premises, therapeutic programmes, services, staffing, and a lack of individual plans for patients in these settings as well. And I just want to talk you through some of the figures in the report, because they're quite stark, and they break down each hospital, each acute centre. These centres are licensed as well, and there's conditions attached, as you know, to these centres. And I'm just looking at a couple of them. The psychiatric unit in Waterford, 2017 compliance 77%, 2018 73%, 2019 67%. That's going in the opposite direction. The same then in a number of other areas. And if I can just go on to where they break down some of the compliance areas by area. Premises 31%, individual care plan 52%. And by the way, it was 57% in 2018. Rules on ETC, 45%, down from 58%. Rules on seclusion, 21%, down from 33%. Admission of children, 7% compliance, down from 11%. So how can you, as the person who has, one of the people who has responsibility for this area, stand over situations where you have the independent regulator saying that residents are being treated as second-class citizens, that their fundamental human rights are being breached, and that many of these residents are being treated in places that are not clean, where there's compliance issues in relation to cleanliness, but also in relation to a lack of individual care plans and other difficulties as well. So when you saw that report and those figures and statistics that I've read, how can you, as a person who's responsible for making sure that those actions are delivered, how can you stand over that report and what's in the report?
Just one point. I suppose we are here. I know you're going to be on the Health Committee and you're going to get it set up as soon as possible, and I completely agree with you in that regard. But we're here just to look at COVID-specific stuff and COVID response. And I just wonder, are we moving
Well, I think a lot of other people
have
have strayed into this area as well. So it's one of the few opportunities we have. I think it's the first opportunity we had in the Oireachtas to actually put questions to both the Commission, because they're here, and the person responsible for the Commission's findings in relation to this very important report, which the report says was exacerbated, by the way, because of COVID. So they do take account of that situation as well. So if you can just maybe address the questions I put.
So we have, if you've seen from the report of the regulator, we have until the 24th of July to provide a response to that report, and that will be the report that we're working on as we speak will go into all of those areas that you've raised, and ones that we are very aware of and have been aware of, and that I think that's the best way of answering it in the short time that we have, because there's a lot of detail in what you've said there. But I can assure you that I can provide that documentation. We'll go to the Commission in the first instance as our response from the HSE.
Well, I've gone through all of these reports, and there's a history of these reports going back over the last number of years, all pointing out the same shortcomings, all pointing out the same problems, all pointing out the same failures. In fact, you will be aware of my own constituency, there was a number of reports that were published specifically about the Department of Psychiatry unit in University Hospital Waterford. It doesn't seem to be improving. I've given you the example where the figures are going in the wrong direction. So they're pointing out their staffing problems. If you go back to the report in the Waterford unit, where it was not clean, overflowing with bins in some toilets, cigarette butts in toilets, stains in toilets, patients on floors. I mean, it doesn't paint a very good picture at all, does it, of some of these centres and how patients are being treated. And I'll come back to the point, because it is a fundamental point, COVID or non-COVID. If you have a situation where you have the regulator saying that some patients are being treated as second-class citizens, I mean, that's a damning statement for the regulator to make, and I'm sure it wasn't made lightly.
I suppose Mr. Ryan has said he'll provide a written report, but if there's anything you want to add, Mr. Ryan, go ahead.
If I can come back maybe to the regulator, if I can, if I can maybe just come back to Mr. Farley. Can I just come to the example of University Hospital Waterford, because I do know something about this unit. It's in my own constituency. You point out in your report, as I said, if you look at the breakdown of the figures, where the overall compliance is going in the wrong direction. But yet then when it comes to the conditions removed, there was conditions removed for the unit in Waterford. How is that the case if the overall compliance was going in the wrong direction?
Yeah, so, well, first of all, the conditions are supposed to be specific to solve a particular risk. But, I mean, Waterford is a really good example of how things can go wrong in a system. And if you track back over 20 years, the closures of the different hospitals, the lack of community services, and then what you get is people going into this place, overcrowded, over capacity, and because the clinicians are afraid that if the person is outside, that they will come to harm themselves. So there's a whole systemic thing. There's also a governance issue that you're pointing to in the HSE, and it's something that we're raising with the HSE. There is a board of the HSE, and mental health really needs to be brought up the agenda. The old government policy was that there was a national director for mental health. That person was taken out, so that was contrary to government policy. Definitely the improving of the community services. But that whole Area 5, CHO Area 5, Rosemary, we've done an awful lot of work with there over the last 6 or 7 months, because, the decision for us is this place really, this is not good, something needs to stop, but then you don't want to leave the families and the residents in the lurch. So,
just have one final question, Mr. Farley, and if things are improving in Waterford, that's fine, but what I'm pointing out is your report shows that the compliance overall is going in the opposite direction. And I'm just looking at page 24 of your report, where you talk about the enforcement model. So you have the option to remove a unit or a service from your register. Have you ever done that?
No.
Why not? Why? Is there a reason? Is it that things haven't got bad enough for that to happen?
Well, I think on balance, it's a big decision to make, and that you have to think who will suffer because of this. I mean, we were looking at one. The one that we were really going after this year is actually being replaced, and that was up in Sligo, where it really was physically just wasn't acceptable anymore. That's being replaced. But I mean, I don't think it would be in anyone's interest to close the unit in Waterford, but I definitely think that it is improving. And one of the models that we use is transparency, because people get forgotten about. And so the idea of transparency, and people like you being able to read the report, wakes people up to the reality of how we're treating people. And that to me is the best weapon.
Well, I should point out in conclusion, I wasn't advocating that we close any unit. I'm just asking the question. It's one of the powers that you have, and if things got so bad in some of them that it did warrant a closure, I was just wondering maybe why those powers weren't used. But the main point I'm making is that, and if Waterford is an example, it's still not a great example because they haven't improved to my satisfaction. But I would imagine that what you're saying is that it's a carrot and stick to some degree, and that you want the HSE to solve the problems which you address. My point is that time and again in some areas in relation to premises, in relation to staffing, in relation to cleanliness, time and again we're seeing problems, lack of individual care plans, they are not being addressed. And that's a fundamental problem for me because of the vulnerable people here who we're dealing with.
And I agree, and it's a fundamental problem for me, and in this year, in terms of the response we get back, but it is about the governance, the board, the CEOs, the people that sit at the executive committee, the politicians. We have to own this. The idea that 50% on the care plans, which I trained in England like 30 years ago, that's just a given. And in Ireland, you seem to nearly have to, force people to do things. And you know what? You're not going to get staff to come into our service if people can't even do a basic care plan properly, because that's what it's all about, basic human rights and working with the person. So I agree with you. What I can assure you is, in terms of the Commission, we have a new strategy which started last year, and our tolerance levels, it's gone now. So you would have seen our first prosecution in Kilkenny. But I really would add that there's people, it's not just Waterford, the people of Wexford, all that area down there, Kilkenny, that's an area that needs a lot of work, particularly in community services, if we're not going to have the right amount of beds in terms of acute.
Thanks very much. Now we'll move back to the COVID response.
Well, I think if I can continue on some of the questions following on from them, and if I just welcome our witnesses and welcome, in fact, the improvements certainly in Drogheda and the Cross Lanes facility. There are still issues about people who may still be in drug treatment and can't get care because they're still on the drug that they're dependent on. But that's a separate issue. I think just the statistics, as I understand them, is that 1 in 5, according to the OECD, of our citizens have mental health issues, and that we have the lowest bed capacity in Europe. I think 34 beds per 100,000 compared to the European average of 69. And I think that adds to the point that Deputy Cullinan was making. And the fact that I think on average, if you have severe mental health problems, that you'll on average live 20 years less than your peers of the same age. So it is a huge issue, and you're quite right, Mr. Farage, to be concerned, and all of us are concerned, and we support what you're saying, that the system is not fit for purpose. And COVID is allowing us to contribute to the debate here. And I think I would agree to put it top of our priority from the politician. I'm a government supporter, and from the opposition. We need to get this right. So my question is that because of the very significant readmission rate, I think it's something like 64% of patients who have been in care or in hospital or whatever, in treatment, they go back in. Do we need to have different responses in terms of appropriate recovery step-down facilities? If you can comment on that, please. That do we have inadequate, or do we have any step-down facilities where people who have been in treatment, they go back to the community, but they need a period of care outside of the acute setting?
To comment in a moment. Just as a precursor, I suppose, as you're aware, under the Vision for Change Refresh, Vision for Everyone, that envisages a review of the acute bed capacity in the country, and I think that's welcome and timely, and one in which the HSE will absolutely be involved in, and I would hope that it will over time address the issues that Deputy Cullinan raised earlier, and one in which we, as a country, we had 20,000 people in psychiatric hospitals in 1960. We now have about 1,039 beds. So we have actually moved much of our care to the community. But we do also have to be cognizant of the fact that perhaps at times the pendulum may swing too far. So Dr. Niazi, maybe particularly in relation...
You have half the bed capacity of the average European state. I mean, that's the point I'm making. And that's obviously for us to address. But the question of step-down facilities.
Mr. Dowd, first of all, can I say that certainly we'll welcome a review of bed capacity. I think acute services have already started. I think there is a meeting that's happening today. We'll welcome. The other thing I'll say is that it's an opportunity now. We have the sharing of vision. We have the program for government. We can plan, sit down for the next 10 years and see how it is done. I welcome Mr. Farley's recommendation that we'll have to take a unified approach to deal with all of that. The reason why I'm saying is that in the previous years, even when government allocated funding for mental health services, there were times that we were unable to use them. A lot of our funding goes to manpower. Even if we have services have funding, they couldn't use it because the consultants were not available, the nursing staff were not available. And as Mr. Ryan says, that now taking a unified approach, like we are working with our NDTP and the training college to see for the next 10 years how many consultants we need to train. Similarly, our nursing colleges are looking at what numbers will be required over the next 10 years, how many beds we need, how many units we already have made as our single occupancy units.
I don't have an issue with what you're saying there at all, and I support it, but it's a different question.
Yeah, no, coming to your question, what we had the acute units and we had the day centers. What we are trying to do now is trying to open up day hospitals as a step down from acute admissions. Most of our day centers, we want them to go into community resource facilities, whereas the day hospitals will have a very targeted approach to admission, so that instead of somebody going into admission and have nothing in the middle, the day hospital model that we are trying to bring in as a multidisciplinary model to address that gap that we had. So I think that is the answer. I can say that moving from a day center to a day hospital will be a step down from acute admissions that we are trying to do.
I think the other point is that there is a need, I believe, for residential step-down facilities, which would be far less expensive than the, than the full acute care. But I can talk to you about that later on. The other question I have is that if we have over 30,000 people in nursing homes at the moment, and if on average 70% of those have dementia, and there seems to be a very significant relationship between dementia and psychiatric comorbidity, if that's the right phrase to use, and in view of the fact that that thousands of people living in nursing homes have lost a very significant contact with their relatives and with their community interactions, what interaction do the psychiatric services, in view of this COVID issue, have with nursing homes generally? Is there any formal relationship, or how do you react, or what proposals do you have in that respect?
Again, if you really ask, during the COVID, our services were not stopped. Like, all our acute units continue to function. All the psychiatry for later life teams continue to function. They had a different way of providing services. We made the best use of technology, whether it was phone, whether it was Blue Eye or Attend Anywhere, or even Zoom calls. We tried to keep that contact. But at the same time, face-to-face were limited because of the public health guidance and all those documents. But I have never heard of any services withdrawn. Yes, they changed the way they were providing services to nursing homes, and that's the best evidence I can say. Going forward in our model of care, there is also a discussion going on for allocating resource for people who are in nursing homes, and also people who are as a liaison services in acute hospitals, because we feel that more than 70% beds in our acute hospitals are filled by over 65 years of age. So I think that is an area which is highlighted in the model of care in our psychiatry for later life, and that is something which again we are looking at in our 10 years program, how we can improve that.
I think just finally, just a question is, I appreciate the answer and respect what you said to me, but the question is, what formal relationships you have had since COVID with nursing homes generally, if any? Is there any network there now?
I'm not aware of formally, Deputy. I suppose the way we operate is through our psychiatry of later life and our old age psychiatry service. And so if an individual has an old age, has to be seen by an old age psychiatrist, then they're referred in the normal process to our psychiatry of later life teams.
The point I'm making is a different point. Is that people, if 70% of these people have some psychiatric problems or issues, 70% of the 30,000 residents, I suppose, what should you be doing? Or can you come back to us with a model or a proposal? I appreciate we haven't much time now to answer now, but do you see that as an issue that urgently needs to be addressed?
I'll go back to the faculty of later life and clarify that, and can write it back to you, the response to it.
Thank you very much, Dr. Niazi.
Thank you, Chairman. Yeah.
Deputy, I think technically it's, yeah, go ahead, your 5 minutes.
Thank you, Chairman, and welcome to the witnesses as well. Thank you very much for your presentation today. Very interesting, and thank you for the report in advance. I represent Dunleary in the Dáil here, and one of the big issues I've had over the years has been the staffing resource for CH06. It's been difficult to retain staff and to indeed recruit staff in various departments. But specifically looking at CAMS and how the children and adolescents sector is resourced, could maybe the HSE comment on the overall recruitment process? I don't want to be too parochial here, but certainly the level of staffing that in terms of mental health has been filled so far. If you wouldn't mind coming back to me on that, please.
So I'll start, and the service that's been provided in the Dunleary area, as the Deputy will be aware, is run through the Lucina service from the St John of God's service. So there are different parts of the country will have different challenges in terms of recruitment, and the South Dublin area we have found previously to be challenging from the perspective of recruiting, particularly AHPs, and that can be down to lots of issues in relation to economic issues, etc. So if you look at the moment at our Vision for Change numbers, we're approximately across the country, we're probably about 60-65% of our of what Vision for Change would have said in 2006. We have over 70 teams that are in place now. The recruitment challenges we have found are particularly around specialist areas, and CAMS is one of those. And perhaps Professor Doody might comment more specifically, because he's involved on a day-to-day basis in running a unit.
With regard to staffing, I think that there are particular challenges, particularly in South Dublin, with regard to recruiting and retaining staff. And there may be issues which are not linked necessarily with the services themselves, but with kind of more people's personal circumstances. So that is one issue. I think that overall, one is to be mindful that as you grow services need to be grown in a sustainable way, or else all that happens is that very skilled people just move from one service to another. So so it's important that services can only be grown at a sustainable level. There needs to be a proper plan with regard to growing services in a way that you train the particularly AHPs and other specialties that you require to staff multidisciplinary specialist teams. Then the other issues, and again, you're looking at physical infrastructure as well. You're looking at as well with regard to inpatient services that there's quite a significant timeline with regard to bringing inpatient services on stream, from design to building to roll out. I think you must remember with child and adolescent mental health services that Vision for Change document in 2006 made a very significant change in that it recommended that the age range for child and adolescent mental health services be extended to 18. So we were looking at services that up to then had been resourced for under 16s. So effectively there was a very significant additional investment that needed to be made. And I think over the last number of years there has been a significant increase in the number of teams and the number of staff, and some of on these teams, and some of this growth has been limited by the availability of skilled professionals. But also one needs to be mindful is there's been significant population growth as well. So it may appear that even though there's investment and new teams have been developed, one also needs to take into account that there's been significant population growth over that period of approximately.
Thank you for that. I'm just conscious of the time, but thank you for that response. And all I would appeal to the Director and indeed to the staff from the HSE in particular is to keep that focus on South Dublin. I know of the challenges, as I say, I'm aware of it for many years, but certainly to redouble the efforts in retaining and recruiting staff for CH06 and the wider field. Just before my time concludes, I raised in the earlier session about dual diagnosis. It's a problem time and time again about people who have addiction who equally have mental health issues. If I could get a comment on that, please. And then also about primary health care services. It's patchy, to say the least, across the country. Some areas have a very functioning primary health care service and indeed a centre. Others don't, and that presents its challenges. And then finally, to the Mental Health Commission, I would just highlight on page 17 of the report that we received in advance of this was that you were on a weekly basis reporting to the Department of Health. And I'm just wondering if the second wave of COVID were to hit, or during the next few weeks and months, is that likely to continue? Thank you, Chair.
Could I just ask that maybe you could briefly answer the last question, because it's COVID related, and could you perhaps provide a reply in writing to Deputy Devlin with regard to the other questions?
Thank you.
So in relation to the last question, we've been watching that very, very closely, monitoring it. In fact, we had a particular risk framework that we used to ascertain if a centre could react, even if it had bad premises. So Rosemary has the exact details here in terms of what we're requiring.
Just to clarify, is it that we will continue to report to the Department of Health? Is that the question, Deputy?
Basis, yeah.
Yeah, we're still continuing to report on a weekly basis the numbers. Each week we submit a summary report and the metrics to the department and to the HSE as well, and we will continue to do that as long as it takes.
Okay, thank you very much.
Thank you.
And if you could just provide a reply in writing on the other questions.
Deputy
O'Reilly.
Thank you very much, Ciara. And thanks very much to our witnesses for coming in, and thank you for the information that you've provided. My first question is to Mr. Ryan, and it relates to a question asked earlier by another committee member in relation to the forensic services and the low level of COVID in the forensic services. Am I right in saying the forensic services is one building, or are there additional services throughout the country?
So the Central Mental Hospital is the one building in Dundrum, as you know. We also have Ushers Island in the city centre, and obviously our prison in-reach staff go into the main prisons across the country. So as a forensic service, we're national, but the Central Mental Hospital is within one facility in Dundrum. And as you're aware, we also opened a 9-bedded unit as a response to COVID in the new facility, but that has since, we have moved patients on from that since.
Mm-hmm. Yeah, so I'm just when you say the forensic mental health services, it does sound like multiple locations and all the rest of it. I mean, it clearly isn't that. What date did you restrict visitors to the CMH? Obviously, Ushers Island would have been closed, I imagine, in the early stages, and then the visitor restrictions to the Central Mental Hospital would have kicked in. What date was that?
So I can't remember exactly. It would have been in line with whatever the recommendations of the public health authorities at the time.
So it was exactly in line with NEFIT. You didn't close ahead of that time.
I don't think we did.
Okay, Mr. Ryan, can I ask you to check that so that you're certain, because that's not my understanding, and you might correspond with me on that. That would be very helpful. I mean, you and I, and I'm sure the other witnesses here are more than familiar with the Central Mental Hospital. It has a massive high wall around it and double gates at the front. So indeed, it's very hard for anyone, or indeed anything, to get in or to get out of it. Similar to the prison setup. So I just, I wouldn't want the impression to be given that this was a kind of an open facility when clearly it wasn't. With regard to the restarting of care, and my apologies if I've missed this because I have been dipping in and out to the evidence, is there a plan for catch-up on services that have been missed, or people who might require more intensive engagement and more intensive therapy? Is there a plan to catch up? Because we all know, and we've spoken at length about the impact that this pandemic will have on the mental health of the general population, but even more acutely so in those who would have been users of the mental health services.
So I might just start generally, and Dr. Nazi will follow on. We've the HSE, as you're aware, produced a document on business continuity, which essentially means that we've all looked at our own services from the care groups to look at what do we need to do now to bring services back on stream. So that plan is almost complete, and so what we're trying to do look at is what can we do safely, what can we use some of the technology that we would have already learned about the last couple of months, and also then we need to take into account that potentially what impact there may be for a second surge or a second wave. So Dr. Nazi, you might just...
in relation to the startup of the services, first of all, as I said earlier, that our acute units continue to function 24/7. Our 24-hour residences were open with limitations to visits. The services which were impacted were our day centres, day hospitals, group therapies, group activities. And again, they are gradually starting again with social distancing, with all the guidelines from HSPC that we are following. The COVID has impacted general public, not only mental health, and who do require support from mental health services. So HSE has worked very hard on a psychosocial and mental health needs of general public. And they are targeting carers, they are targeting families, they are targeting even staff who got impact from the COVID-19. So it's a comprehensive national plan that they are rolling out for the general public, for the staff, for the carers. And in relation to the secondary mental health services, as I said, yes, we are starting back slowly and gradually, keeping the guidelines from public health and from HSBC. And I think it depends upon how successfully we manage to control the virus. And I think that will guide us how we will restart.
And in terms of so there's no specific catch-up campaign, as you've said there. Just with regard to the recruitment issues, so we know that in advance of this pandemic, there were serious recruitment and retention issues. We know in part that those were caused by recruitment embargoes imposed by the previous 3 governments, much and all as their members come in and give out about it now. So with regard to the catch-up, which you haven't outlined, the restart of services, which were already understaffed, is there a specific recruitment campaign that you have identified, and do you have a target for the number in each grade group and category that will be necessary? Have you got a target in mind? Is that target published?
So that target has been published as part of our business continuity. What we're looking at is what level of service do we need to bring back in a safe way, and that depends on whether it's inpatient, day programmes or community. So that number, Deputy, will be determined by our business continuity plan, which, as I say, is being worked on at present.
Okay, so you referenced there, Chair, if I could, just one more question. You referenced the use of technology. Now, I have my own opinions about telemedicine, particularly in the area of mental health. I've made those views known. I'm sure you're well aware of them, Mr. Ryan. But I'll just draw your attention to some information provided by the Samaritans, in which they say phone calls, so they're talking about an increase in the number of emails because callers are finding it difficult to talk on the phone in private during the lockdown. So, I mean, this is not an ideal scenario at all, but it was a stopgap. And I would hate to think that that which was a stopgap and not ideal would now somehow replace face-to-face services. But what they say in this, it was part of a presentation, but what they say in this slide is that phone calls appear to centre on a need for human contact. So replacing face-to-face services, even in a socially distant way, replacing those services, it will never, ever be right if they are replaced with telemedicine. I don't believe that has any place, and we can see when those services were replaced with a telemedicine service that the Samaritans are reporting that their callers, that calls appear to centre on a need for human contact. So could you provide details for us as to how many of the services are going to be replaced with a telemedicine service, and perhaps if Dr. Niazi could give his own view on whether or not that would be an adequate replacement for face-to-face services. Thank you.
You're absolutely right. When we are sitting with a patient face to face, it's not only the words that a patient says, there is a lot of other things that we look at. We look at their body language, we look at their hygiene, we look at all the other dimensions of our assessment. Secondly, there are patients who even are paranoid, who are not well when they are on the other side of the phone and because they have their own anxiety about the technology. But it was used in pandemic, and we are not saying that we are replacing it. In fact, even during that pandemic, when the use of technology was happening, if a doctor was concerned about somebody's mental health, or if he felt that the information required from those assessments was not gathered appropriately, they were asking patients to present to the acute units, where separate areas were developed, keeping social distancing, keeping all those guidelines in place. Now, since the pandemic is settling a little bit, those face-to-face assessments have started to increase. As I say, it's patient need that dictates that how much of that can be done by technology. If a patient says that I'm not sleeping and I need a sleeping tablet, yes, we can address that issue. But if we feel that his assessment requires face-to-face detailed assessment, patients are invited in our units, and we are looking at all our outpatient areas, our sector headquarters, looking at their layouts, what needs to be done to make them safe. So I totally accept we are not replacing technology, but that's another arsenal in our tool that if we need to use that, it's available.
Thanks. Thank you, Deputy Riley. Thank you. I just want to follow up on that. It's been suggested to me by somebody who works in the HSE mental health services in the Midwest that there's no consistent or coherent plan around when or how to return to face-to-face meetings. Could I invite the HSE representatives to comment on that, whomsoever wishes?
So what we're attempting to do at all times, and as you're aware, the guidelines can change, is to stay within the public health guidelines. And as part of the return to business protocol, that's been published, and that needs to be worked out on an individual area basis, because you can have principles and guidelines, protocols, but you also need to be able to implement them. So each of the areas at the moment, as we speak, are actually looking at their own premises and their own services in order to look at how exactly are we going to meet the twin approach of return to some degree of normality. Then
it is correct to say that there is no consistent plan in place yet. It's still being worked out.
Well, what's happening is that the guidelines that have been issued need to be implemented at local area level.
So they haven't been implemented yet at local area level?
I think we're in the process of doing that, Deputy.
Okay, thanks. Then with regard to more remote care, it's been suggested that rather than having smartphones, that the staff have Nokia 3210s. They're the kind of phones that they used to use in love-hate for very different reasons. And that they've no handsets. They're still waiting approval of video conferencing facilities. Could you care to, and this is several months into the coronavirus restrictions, would you care to comment on that?
As deputies can appreciate, there was once COVID hit, we had to look at all ways in trying to make sure that we could try and continue to provide services. And from an ICT point of view, that posed significant challenges. However, there's been huge developments over the last couple of months, probably greater than we would ever seen feasible. And the issue you raised there about devices, that certainly has been a difficulty over the last period of time, but we would hope that that will no longer be a difficulty into the future, because our investment in those devices will help to meet the demand. Also, Deputy Riley mentioned earlier about face-to-face. What we're looking at trying to do is have a blended approach, so that those who do need face-to-face can have that access, but that we also make sure that we try and maintain a level of service and we use technology to the best advantage. But as you've outlined, that coverage across the country can be sometimes patchy, and that's something that we're working on a daily basis.
Thank you. excuse me, I'm looking at a WHO report on COVID and mental health, and it states reports from Chile, Italy, Spain, the Philippines, the United Arab Emirates, the United Kingdom and the United States of America document how dedicated teams provide mental health support for healthcare workers. Were there any such teams, dedicated teams, in the HSE or anywhere across mental health services providing mental health support to frontline healthcare workers?
So that in this country, the way we've done that is through our psychosocial response, and as Dr. Niazi mentioned earlier, we have specifically arranged for counselling services through Silver Cloud, and I understand there's been about 3,000 counselling sessions taken up by our 3,000 staff. The HSE have taken up that offer already. So what we've done is that we've used technology, I suppose, in a way in which to our benefit. I think, Doctor, that's probably the main way in which we've addressed it.
That's the main way at the moment.
Thank you. Lastly, I suppose it's would you agree that the impact of COVID-19 and the restrictions which were necessitated had a negative impact on mental health? Yes. Or not?
I think they've had a negative impact across the whole range of health services, and notwithstanding in mental health.
So I'm not saying a negative impact on mental health services, but a negative impact on the mental health of the population.
Yes.
Yeah. Given that, do you think it's either surprising or alarming that there was no mental health representatives or representatives of psychiatry on NEFIT when all of these decisions were being made?
I don't know. I don't think that's.
Maybe if you don't wish to comment on that, maybe the Mental Health Commission might wish to comment, and if they don't, that's fine.
My understanding is that Dr. Siobhan Nivreen, who was previously the clinical lead in the HSE, was on the NEFIT.
But my understanding is not as a representative of mental health or psychiatry, but rather in her new role. Is that correct?
Yeah. Well, I don't know, but I know that we inputted into the structure in terms of the vulnerable person as well, and there was a fair bit of professionals who understand mental health feeding in. I suppose the context is now and getting ready again when we know we have a service that, and I really want to reiterate this, I really wouldn't want it to get lost, and I appreciate that the mental health of the nation and individuals is important, but within that there's highly vulnerable people with mental illness who really need to get the service, and I suppose for me they're the ones that I really would like the HSE to concentrate on building a service for people with mental illness.
Okay, you've been very clear with that message, Mr. Farrelly. Thank you very much. I'd also like to thank Mr. Ryan and Professor Doody, Dr. Niazi, and also the other people from the Mental Health Commission, Ms. Rosemary Smith and Dr. Finnerty. Thank you all very much for coming, and with that I'd like to adjourn the meeting until no, but aren't we till Thursday? Okay, sorry, we're meeting again today, of course, in private session. My apologies. I'm suspending until 4:30 when we're meeting in, or 4 o'clock rather, when we're meeting in private session to discuss reports and some upcoming meetings. But thank you very much to our witnesses for coming in and for answering all of our questions. Thank you.